Okay, everyone, let's go ahead and get started. Good afternoon, everyone, and welcome to today's conversation series program focusing on managing alcohol use disorder and medical marijuana use in transplant candidates. My name is Christina Wheeler, and I serve as a program consultant with the Alliance. The Alliance Conversation Series is meant to be a fast-paced, collaborative opportunity. Today, through shared insight, our panels of experts will discuss what is clearly a very important topic for the community. We encourage everyone to participate and to engage our speakers and be involved in the conversation today by using the chat feature in your window. Let's see if I can advance my presentation here. Sorry, hold on. There we go. But if you locate that chat feature in the bottom of your Zoom window, please feel free to submit your questions or comments at any time. Additionally, if you're joining us as a group, please complete the following poll to indicate the approximate number of people who have joined with your group. Now, to get us started, click here, sorry, next slide. Thank you. Okay, now to get us started, I'd like to introduce our moderator for today's session, Megan Bell. Megan serves as the Director of Clinical Operations at Keck USC Transplant Institute, and Megan is also a valued member of the Alliance Conversation Work Group. Megan, I'm going to turn it over to you now.
Great. Thank you, Christina, and thank you everyone for joining. We have a great presentation, and really, as Christina said, our goal is for this to be an interactive conversation between all of us as well. I'd like to first introduce our speakers, though. Our first speaker is going to be Dr. Scott Winder, who is a clinical associate professor in the Department of Psychiatry, Surgery, and Neurology at the University of Michigan. Dr. Winder holds a medical degree from the University of Utah School of Medicine and a Master's of Science degree from the University of Michigan School of Public Health. He completed a general psychiatry residency and a consultation liaison psychiatry fellowship at the University of Michigan. As a consultation liaison psychiatrist, Dr. Winder specializes in the psychiatric care of the medically ill, and in this clinical niche, he has co-founded specialty clinics embedded in organ transplantation, neurology, and hepatology, working on interprofessional teams and providing integrated psychiatric and medical care to patients whose disease crosses medical discipline. Dr. Brian Lee will be speaking after Dr. Scott Winder. Dr. Lee is an NIAAA-funded transplant hepatologist that specializes in patient care before and after liver transplant. His research focuses on improving health for patients with alcohol use disorder and alcohol-associated liver disease through early liver transplant for alcohol-associated hepatitis, inequities in healthcare access, public policy and advocacy, and novel therapeutics and translational studies. His research has resulted in first author studies published in Annals of Internal Medicine, The Lancet Public Health, JAMA Internal Medicine, Gastroenterology, Journal of Hepatology, and many others. His research has featured in national media with NBC Nightly News, Today Show, NPR, CNN, Forbes, Los Angeles Times, Wall Street Journal, and many others. His research and advocacy has led to changes in national and California transplant and insurance policies, and has incorporated into practice guidelines across North America, Europe, Latin America, and Asia. And finally, Dr. Mellinger will be speaking. Dr. Mellinger is an assistant professor in internal medicine and psychiatry at Michigan Medicine, where she practices clinically in general and transplant hepatology with a special focus on alcohol-related liver disease. She holds her medical degree from Northwestern University Feinberg School of Medicine and a master's degree in English literature and the history of medicine from Oxford University, along with a master's in health and healthcare research from the University of Michigan. Her clinical practice and research focuses on the epidemiology of alcohol-related liver disease, cost effectiveness of and access to alcohol use disorder treatments among those with acute liver disease, and developing novel behavioral interventions to help patients with alcohol-related liver disease stop alcohol use and engage in alcohol treatment. Along with her colleagues in psychiatry, in 2018, Dr. Mellinger founded the Michigan Alcohol Improvement Network's multidisciplinary ALD clinic, one of the first fully integrated, co-located alcohol and liver disease treatment clinics for ALD patients. She is NIH funded through the NIAAA and NIDA to study behavioral treatments and ALD. So I'd like us to welcome all of our speakers, and we're going to get started now. Thank you.
Thanks to the Alliance for inviting us, and it's a real honor to be alongside Dr. Mellinger and Dr. Lee, both colleagues and friends. We've got some short slides just to try and set the stage and maybe anticipate some of the questions that will come up. And so I'll move briskly. We're slotted for about 8 minutes each, and I'll try to remain close to that. I don't have any relevant disclosures to today's presentation. We did understand and get a chance to see the questions that were coming in beforehand. There's a lot of questions about cannabis. And so I just want to direct the audience to a paper that we really put a lot of time into. Prestigious transplant journals did not love it, but it did find a home. And so a lot of the information that we will draw on with cannabis is contained here. And so this is a little bit of a efficiency plug for a paper that might answer some questions if in fact today's discussion doesn't reach everything. We're proud of this. This is multi-institution. We put a lot of time in this. So I do submit it to you for your consideration confidently on those grounds. I did want to flag just some general ways in which psychiatrists within transplant centers and psychologists and social workers interact with the idea of cannabis and alcohol. These, each of my slides will be divided among these two substances, but these are kind of 4 general challenges that arise that I'd at least like to make a brief pass over today in my brief remarks. So a lot of times psychiatrists and psychologists are asked to kind of comment on the pharmacologic interactions of ethanol and THC and other cannabinoids. And you'll see that ethanol we know is metabolized by alcohol dehydrogenase as well as interacting with some of the cytochrome enzymes. But it really doesn't have a lot of drug-drug interactions per se. It does affect the clearance of other medications and does interact with other CNS medications, causing symptoms like sedation or tachycardia, or boosting the likelihood of intoxication. There are obvious confounders, including a patient's alcohol-related liver damage and other nutritional considerations. And it just is a very common interactor, so to speak, with many, many psychiatric, neurological, and pain medications. So this is always on the table when we're discussing on transplant teams where alcohol use is not necessarily a contraindication, how big of a deal this is. Cannabis, there's very limited data about its drug-drug interactions, a lot of that because it's been stigmatized and understudied, and there's no standard recommendations for dosing adjustments. THC and CBD, which are 2 of the prominent cannabinoids, do interact at 1A2 and 2C9, and CBD has some other activity, which you see there. These do interact with tacrolimus and other calcineurin inhibitors due to the 3A4 inhibition. We're often asked about psychiatric risks. I just wanted to flag a few here. Many of us are familiar with these regarding alcohol, but in the transplant world, this literature exists mostly in liver transplantation. Alcohol use disorder, alcohol addiction is chronic and common, it's relapsing. And the unfortunate reality is that alcohol use disorder treatment rates in people with alcohol-related liver disease are abysmal, and they're not much better in the general population. Dr. Mellinger's done great work on this, showing that less than 1% of patients who have alcohol-related liver disease, as an example of this, ever get access to an FDA-approved medication for alcohol use disorder. The highly comorbid condition, alcohol use disorder. And in the general population, you see elevated odds ratios for mood, anxiety, and other drug use problems. And we see this, I know you all do, that polysubstance use is extraordinarily common in alcohol-related liver disease and other manifestations of alcohol problems in the transplant center. Cannabis is known to associate with challenges regarding mood and anxiety, psychosis, cognition, and addiction. There are data within general and transplant patients in this regard. Synthetic cannabinoids, which are designer drugs which interact with the cannabinoid receptors like K2 and Spice, or their street names, are even worse in their psychiatric profile. We don't see this much in the transplant center. As a patient's use goes from like not use, never users, to use, and then use disorder, there is a rather convincing accumulation of psychiatric risks and comorbidities. And the articles cited at the bottom of the slide are international in backing that up. National survey data show that the amount of people using cannabis can be as high as 1 in 5. And depending on the study, anywhere between 6 and 10% of people avidly using cannabis have a use disorder. And the New York Times is not an outlet that necessarily concerns itself with the morality or any stigma relating to cannabis. And yet there still are recent questions, you all probably saw this, about how smart is this, what we're doing with cannabis, since it's such a popular thing nowadays. And then I get a kick of reading Dr. Lee, his own data here. There's so much we could say about this, and Dr. Lee and Dr. Mellinger both are very esteemed in this regard. I did want to zero in on early transplantation because of some of the concerns that are rising with regard to graft risk. And Dr. Louvet's group has shown that in a study published by The Lancet, that earlier transplantation does actually lead to higher rates of alcohol relapse at 2 years when compared to the more traditional 6 months of sobriety. And so while the survival rates were the same, there is a signal that as we take on higher acuity alcohol challenges in the transplant center, we are seeing relapse rates that are higher, not as high as in the general population per se. And this is of note to the graft risk. And then here is Dr. Lee's data that shows that there are some survival implications, of course, as patients return to alcohol use, both of the non-heavy and heavy kind as categorized in this study. In terms of cannabis, we know most about this from the liver and kidney literature. We know that a lot of liver recipients, from a great paper from Jan and Foreman from 2021, a lot of people actively are using cannabinoids. And these patients, while they don't have, there's no convincing evidence of any unfavorable impact on kidney graft failure, mortality, or some of the liver transplant list metrics like time to listing. We do know that patients who use cannabis tend to have higher psychosocial risks. And that's a notable maybe pearl, is that while the cannabinoid may not affect the organ per se, it travels with some things that the psychosocial clinicians and the team in general should know about. Lung transplant risks are a little bit more medical, we might say, in nature, that chronic bronchitis has been identified, as well as exogenous lipid pneumonia from some of the vape cartridge products. And there is this Okahara paper that I cite here, where the donor's heavy use of cannabis did portend and predict and associate with lower 3-year graft survival. To finish, we are always balancing resource stewardship with patient advocacy. There should always be tension between these two. It's uncomfortable, but necessary. And in a review of 70 studies, 90% of them liver, given the preponderance of substance use within this population, there are some themes that are really fertile and thoughtful regarding what studies talk about with regard to the ethics of transplanting patients with substance use: personal responsibility, medical utility, moral character of the person, and fairness. And then there is this kind of continuum of the likelihood of success and medical utility that we're always moving across these two ideas. And again, this should all be on the table as we have these discussions amongst ourselves. And my final slide here, again, zooming in on some of the more acute and innovative aspects of alcohol use in the transplant center, is what's happening is centers are now competing to transplant more and more acute alcohol-associated hepatitis patients, which are skyrocketing after the pandemic and after the Matherin New England Journal paper from 2011. And Dr. Trotter's editorial in Transplantation, cited below, even wonders, are these patients getting preferential access because of some of the things that are happening with acuity circles? And we're not really adhering to some of the guidelines like the Dallas criteria. And these patients are younger. We want to rescue them. They have high MELD. They don't have a lot of medical and surgical comorbidities. This is a great, uncomfortable discussion that we should be having. And in terms of cannabis, to finish my remarks, there are some concerns in the literature about stigma, that we think that this drug is somehow wrong or bad or morally suspect when it's just simply a plant. How are we studying it? How are we approaching it? Do we think of it different than other health behaviors? Do we get hung up on its legality, which I don't think is the most important thing? Are we overriding our colleagues in palliative medicine or oncology because we have a strict transplant policy? What about patients who are addicted? We're okay with cannabis on our team, but this patient has a cannabis use disorder. Should we be transplanting them? And how are we applying this decision-making? And of course, the overarching principle above all this is to do no harm. In regards to cannabis, what about a patient who's a long shot for a transplant anyway, and we pull them off cannabis and upend their whole life, and in the end, they don't get a transplant anyway? So this stuff is really kind of tense and difficult, but I'm so glad for the Alliance to have this conversation. Thanks so much.
Thank you, Dr. Winder. Dr. Lee is now going to speak.
So I'd like to thank the Alliance for inviting me and highlighting this topic, which I think is changing so quickly. So I've been tasked to talk about early liver transplant for alcohol-associated liver disease, and really this is an update. I have salary support from the NIH and Siemens, which has no bearing on this presentation. So we'll talk about the history and context of early liver transplant for severe alcohol-associated hepatitis, but also for the broader population of ALD, the outcomes after early transplant in ALD, selection criteria, and then coming back to our own personal practice here at USC. In the US, rates and mortality from ALD have been increasing. ALD is projected to be the single most common cause of cirrhosis in the United States. It currently accounts for 48% of liver-related deaths and 50% worldwide. Alcohol-associated hepatitis, or ALCHEP, is a subset of ALD, where a patient presents acutely with jaundice from alcohol and accounts for 1% of all US hospital admissions, which is a 26% increase in the last 8 years. So severe ALCHEP is, again, a subset of ALD. Compared to patients without patients with ALCHEP are younger and they're more likely to be women. Mortality is up to 70% at 6 months, and there are no pharmacologic therapies that benefit long-term survival. They were historically not eligible for liver transplant, and this was largely due to the 6-month rule, which was an arbitrary suggestion in 1983 at an NIH consensus meeting, where a patient with ALD needed to have 6 months of abstinence to be eligible for transplant. So, at the time, it was the question of whether this made sense. But the fair question is, does it make sense in 2023? One of the initial thoughts was that the 6-month rule would allow time for the liver to recover. A patient with severe ALCHEP might recover and not need an unnecessary transplant. But we now know much more about the short-term disease course. We can predict with high accuracy who will recover and who will not, with more sophisticated prognostic models, like the joint effect model here, which combines MELD and Lille scores. More importantly, the 6-month rule is unrealistic in ALCHEP. By definition, a patient with severe ALCHEP has recent alcohol use. But even though the presentation is acute, the disease is chronic, and over 90% have undiagnosed cirrhosis. Most survivors who present with severe ALCHEP retain an indication for transplant. So this was a large study from France, where 75% of the deaths occurred in the first 2 months. The majority of survivors had a MELD score above 17 at 6 months, and only 15% were alive and without an indication for transplant at 6 months. And finally, mortality in the short term was associated with the inflammatory response, not return to alcohol use. So more recently, we published a multi-center study from Accelerate. We included 145 patients who were evaluated for early transplant with ALCHEP, MELD score greater than 20, alcohol use within 6 months of the evaluation. On the bottom left figure, you have the probability of being alive and recompensated as the dark bar, which was defined as MELD score below 15 and without liver decompensation. The light bar is alive and decompensated. The probability of 6-month probability of being alive and recompensated was only 7%. Probability of being alive and decompensated was 34.7%. The remaining patients, so over 50%, were dead at 6 months. On the right, you have patients who were declined for early transplant because they were thought to be clinically improving during the evaluation. 6-month probability of being alive and recompensated, even in this group, was only 19%, and 69% were alive and decompensated. So another thought with the 6-month rule was that abstinence before transplant could be a surrogate for a patient's ability to abstain from alcohol use after transplant. Since then, there have been a number of studies which show that the 6-month rule is an unreliable predictor of post-transplant relapse. But more importantly, we now know that there are many predictors of alcohol relapse. So why should one, i.e. the length of abstinence, have veto priority above all the others? So we published our results of a multi-center consortium studying early transplant in ALCAP in 2018. The study included 147 patients who underwent early transplant for ALCAP, meaning no period of sobriety for transplant eligibility. Their median time of abstinence before transplant was 55 days. It needs to be emphasized that these patients were very carefully selected. They had no prior diagnosis of chronic liver disease or prior episodes of ALCAP. They all also underwent rigorous evaluations by transplant social workers and addiction specialists. Regardless of the short duration of sobriety, the expectation remains of a commitment to lifelong abstinence after transplant. So as shown in this Kaplan-Meier survival curve, short to intermediate term post-transplant survival is excellent. 1-year survival was 94%. We now have 5-year survival, which is 83%. Probability of alcohol use 1 year after transplant of any use was 25%, and of sustained use 10%. These rates were at least similar to historic US transplant cohorts in alcohol-associated cirrhosis with more than 6 months of abstinence. So our main conclusion here was that early transplant for severe ALCAP is feasible and can be life-saving. So the question is whether this pandemic-related surge that we've seen in alcohol has led to adverse health outcomes. And we've seen this with transplants for ALCAP. So before COVID-19, transplants for ALCAP were already surging. In 2018 and 2019, though, there were more transplants for ALCAP performed than the 30 years prior combined. In 2020, ALD accounted for 40% of all waitlist additions and surpassed NASH and Hep C combined. Since COVID, in March 2020 to February 2021, waitlist registrations for ALCAP increased 325% compared to the 2018-2019 trend. And in January 2021, ALCAP accounted for 8% of total national transplants. Now, ALCAP is the fastest growing indication for transplant both in the United States and Europe. So given this increasing use of early transplant, I'm often asked, who is the appropriate candidate for early transplant? So it's a complicated question, but at its base, can divide into 2 broad categories. The first category is clinical criteria. We're looking for a patient who's at high risk of short-term mortality without transplant, who's too sick and unlikely to survive participation in formal alcohol rehab before transplant, and would derive significant survival benefit from an early transplant. The second category is psychosocial criteria. We're looking for a patient that, despite a short duration of sobriety, would be at low risk for alcohol relapse after transplant, and/or their alcohol use disorder is anticipated to be manageable post-transplant. And with the stigma associated with alcohol use disorders, there's a need that these criteria be objective and standardized. When you have subjective criteria, it can lead to bias and inequity. So to inform the first category, clinical criteria, we developed a Markov model which simulated patients offered with severe ALCAP offered early versus delayed, i.e. a 6-month wait transplant, with varying levels of alcohol use pre and post-transplant. We found that offering early versus delayed transplant increased average survival time of patients a 4.49-fold increase in our base case analysis. The survival benefit of early transplant was maintained in all simulated extreme scenarios, including any estimated risk of sustained alcohol use after transplant. We found that the survival benefit was highest for patients with MELD score of 32 or above, and allele score between 0.50 and 0.82. These are the patients who should be prioritized for early transplant. We also found that 64% of the survival benefit of early transplant is lost in the first 3 months. This emphasizes the importance of an early referral and an efficient early transplant evaluation. So to inform psychosocial criteria, we sought to develop risk algorithms, and one that I'll mention is the SALT score. So this is something that we developed as a secondary analysis of the Accelerate cohort. Our analysis found that there are 4 objective pre-transplant variables commonly collected during evaluation to be strongly associated with sustained alcohol use after transplant, which is more than 10 drinks per day at presentation, 2 or more prior alcohol rehab attempts, any history of prior alcohol-related legal issues, and history of non-cannabis illicit substance use. They were assigned points by loss of regression to form the SALT score, which ranges 0 to 11. At a cutoff of 5, the SALT score had an accuracy of 76% to predict sustained alcohol use after transplant. It has a negative predictive value of 95%, so its most appropriate use is for predicting those at low risk for sustained alcohol use. The maximum positive predictive value at a score of 11 is only 50%. So a recent national survey shows that the SALT score has been incorporated into protocols for more than a third of transplant centers. And the SALT score was recently externally validated by an outside group to have similar accuracy. So the field has come a long way now. There have been changes to national policies and guidelines based on these data. The American College of Gastroenterologists published new guidelines in 2018. The decision of transplant should not be based solely on the minimum 6 months of alcohol abstinence, and other criteria should be taken into consideration. Patients too sick to complete rehab may be considered for transplant by exception pathway, depending on center policy and the patient's profile. The ASLD and the AST released revised guidelines with similar guidance. So this is a key slide summarizing the data that I presented to answer this common question: when do you refer for early transplant? So the 6-month abstinence rule is no longer a strict requirement for transplant. If a patient meets clinical criteria, meaning a allele score above 0.45 severe ALCAP, or a MELD score above 25 if decompensated ALD, and doesn't have other serious comorbidities, and they meet psychosocial criteria, meaning a strong commitment to lifelong abstinence and strong social support, these are the patients that should be referred as early as possible for transplant. So I'll end with our own center level initiatives that we're doing at USC. In the end, clinical care policies and research all need to reflect your own local needs. So at USC, we've seen a dramatic rise in transplants for ALD. In 2021, we did 70 transplants for ALD, which represented 41% of our total liver transplants for that year. 34% of these patients were with less than 6 months of abstinence. And we listed 54% of patients who were formally presented at the selection committee. We've revised the selection protocol to reflect recent advances in evidence. We've eliminated most absolute contraindications like first decompensation, 6 months of abstinence. And we've also tried to eliminate subjective criteria, with the reasoning being that subjective criteria are at risk for bias and to have inconsistent judgment. We've really focused on having a comprehensive evaluation that weighs all the protective factors against the risk factors and coming to a summary conclusion. All transplant candidates are evaluated by a social worker, and all the candidates have a SALT and CyPAT score that are really adjunct tools to the social work evaluation. Addiction psychiatrists formally evaluate all patients who are deemed to be quote unquote high risk by the social worker, and all patients with less than 6 months of abstinence are considered to be high risk. We also have an addiction psychiatrist at each selection meeting. And we're standardized alcohol use surveillance. So we have clinical interview and phosphatidylethanol or PET testing every month in the first year post-transplant. This is the high risk period of the first year, and then every 3 months in later years. And something that we're working on is establishing a multidisciplinary integrated ALD and alcohol use disorder transplant clinic, which we're calling the TRAIL, or Transplant for Alcohol Integrated Liver Clinic. So this is a work in progress, but the idea is that patients would be referred for transplant evaluation with ALD, and they're seen by a multidisciplinary team all in one day. So hepatologist, a surgeon, a psychologist, a social worker, and a nutritionist. We then have a consensus plan for benchmarks needed to proceed with transplant listing. So we had heard that it can be in terms of the transplant team, depending on who you're seeing, it can be inconsistent in terms of the metrics for transplant. So we're hoping that this will have more fairness and more consistency. So with that, we would have benchmarks for medical, surgical, alcohol rehab, diet frailty, caregiving, etc. And then the patients would then be continued to be followed post-transplant with a specific regimen for alcohol use surveillance, alcohol use disorder therapy, etc. And the goal is really to streamline and synergize our transplant team's resources to improve efficiency and consistency, and ultimately to improve patient outcomes. So in conclusion, ALD and LCAP are on the rise. Early transplant for LCAP appears to have acceptable outcomes with careful selection. Our understanding of key selection factors is evolving quickly and is a high priority for research, and further study is necessary to improve outcomes to inform national policy. And finally, even with risk assessment, alcohol use post-transplant will occur and potentially lead to poor outcomes. So transplant centers really need to have resources in place to prevent and treat harmful alcohol use after transplant. And with that, I'll stop here. Thank you for your attention.
Thank you, Dr. Lee, and Dr. Mellinger will now speak.
Excellent. Nice slides up. Everybody see that okay? Right. So following on from what Brian and Scott both talked about, I'll be speaking a bit more about integrated management of ALD and what we do with all of this data that we've been shown now about the rise in ALD transplants and early liver transplant for LCAP. How do we manage these patients in the best way? And really the best way is the integrated way. These are my disclosures, again, nothing relevant to today. So in line with what Brian was just talking about at the end of his talk about the desire to build an integrated clinic to really have a co-located model for managing these patients, this is really where, kind of where we all need to be, and I think where we all need to be going in some vein. Because integrated care for ALD really does work. And this was data from a meta-analysis that was recently published. It showed data for integrated care working in the non-transplant population as well as in the liver transplant population. And obviously, this is a transplant organized presentation, but understand that this is good. This is good management for these patients really across the life of their liver, across the life of that patient, whether they're in transplant or not. And as you can see here, integrated co-located management with mental health, substance abuse working alongside medical hepatology produced lower rates of relapse post-transplant as well as reductions in mortality. And for patients who have ALD, outside of giving them a transplant, there isn't much that we can do to reduce their mortality besides help them stop drinking. So this really prompts a new model where we need to be thinking outside of just the bounds of this kind of time around transplant. I think much of what we've talked about and what Brian alluded to with his talk and a lot of the work that he's done is how do we select these patients? How do we choose patients? How do we determine adequate post-transplant outcomes, mortality, relapse, et cetera? But that still leaves unanswered the question of what do we do about it? How do we really manage these patients across a longer continuum? And so this really begs a new model of care where we treat both the alcohol use disorder and the ALD aggressively across the life of that liver, not just in the peri-transplant period, but also if they aren't a transplant candidate at all, and in the post-transplant period. So this motivated our desire to start a multidisciplinary ALD clinic, largely at Michigan, outside of the transplant network that we have, largely because within transplant, we have an excellent, robust psychosocial team that gives a lot of great care to our patients. But outside of that, we didn't really have a lot. We weren't able really to do a whole lot for our patients who either didn't need transplant right now, maybe they weren't candidates for it yet, they got closed because they didn't meet early liver transplant criteria. Where do we send them? What do we do with them? And so we started our multidisciplinary ALD clinic about 4 years ago. And these are the individuals who were initially part of it. Some have since moved on from Michigan and from the clinic. One important person who's not here who wasn't here that day for the picture is Amanda Johnson, who is our nurse and our case manager and kind of really helps to do population management for our patients. This process of building this clinic, there were some questions early on about how to build a clinic like that. And I can certainly answer some more specifics. A lot of the design of the clinic, the build of the clinic, the business plan and the getting stakeholder buy-in and leadership buy-in took about 2.5 years, I think, with Scott and I working together, going to meetings together with leadership to really make the case for this kind of a clinic. And I think at that time, there wasn't a lot out there about integrated care for this particular population. There was some, but I think since that time, there's been a lot more of a groundswell notice and evidence that's been produced that actually this is really important and integrating this care is critical. So I just wanted to show you a little bit of data from the first year of the clinic. This is about 50 some odd people within our first year. We published this data a couple of years ago. We now have about 230 patients, and I'm, this close to having all of that data finished. Unfortunately, I couldn't get it done in time for this. I apologize. But in broad strokes, these are extraordinarily psychosocially complex patients. So they have a high degree. This represents the range of comorbid mental and emotional health issues that our patients have. And I would say, in our data, 90% of our patients have one of these. So a lot of anxiety, as you might imagine, 3/4 of our patients. And many of these patients have more than one thing. Especially in our female patients, there is a lot of trauma. And we do tend to get a fair number of index disclosures of trauma in the clinic. The first time somebody is ever talking about, the time that they were raped, the time that they were assaulted, happens often in our clinic as they begin to grapple with their alcohol use disorder. But comorbid substance use rates are high. So in addition to the alcohol use disorder, all of which are either moderate, most of which are severe, about 85% to 90% are a severe alcohol use disorder. You have your comorbid mental health disorder. And on top of that, you have a comorbid substance use disorder. And again, 90% of the patients in this clinic have a comorbid substance use disorder. And this is the range that we get. A lot of comorbid marijuana use. So we are dealing with this a lot of comorbid tobacco use. So just there's a range of what people use. Again, people are often using many different, several different substances. But I think the take home from these slides is very much that be aware that these patients are so biopsychosocially complex. The complexity of their liver disease and their advanced liver disease with cirrhosis and alcoholic hepatitis makes the choice of psychoactive medications more complex because many are hepatically metabolized. Many of our patients have renal disorders and lowered renal, have a degree of renal failure. So that can complicate our medication choice for treating alcohol relapse, for treating psychological issues. So these are really complex patients, and it really mandates that integrated approach that we have. When we look at what kinds of alcohol treatment people choose, there's a wealth of data that says if you get a patient with ALD connected to alcohol treatment, you will lower their risk of subsequent decompensation if they're not decompensated, and that you actually can reduce their mortality, even separate from transplant. And again, this is not even including those who get transplanted because they got alcohol use disorder treatment. So getting people connected to some type of alcohol treatment is really critical. And largely what we've seen is that many patients come into us having done AA, but most people choose to go to do one-on-one therapy after seeing us. That seems to be what people choose a lot, though we are able to offer one-on-one therapy, medications, as well as connecting people to things like IOP or residential and other groups as well. In terms of the medications that we see, again, about 2/3 of our patients did come to us on some type of medication for relapse prevention, gabapentin here being the most common. And then in our practice, again, we're using a lot of gabapentin, which is an off-label use of a medication for relapse prevention. It's not FDA approved for that, but does have data behind it to prevent relapse. And then we do use naltrexone and acamprosate in a fair number of patients, and we can certainly talk about that if people have questions. So coming on into 2023, and since fiscal 2019 when we started, we've seen huge growth in the clinic. So we've seen 231 unique patients through that time. We have been somewhat limited by capacity, largely my own and Dr. Winder's my own, because of my current funding on a career development award from the NIH, which limits my clinical ability to grow. But after that, in the next year, we hope to grow to doing this every single week instead of a half day every other week. Over the 3 years or 4 years, pardon me, we've seen nearly 300% clinic growth in the number of unique patients that we see every year. And we have about a 3 to 4 month wait right now. Because of capacity, we are only taking internal referrals, and this is how busy we are. So there is very clearly a huge need for this, certainly in our local community and in our region. And we hope to open up and expand out to external referrals after July 1 in fiscal 24. We have about a quarter of our population that has been evaluated for transplant, either before or after their index visit with us. And we referred about 17 to 18 of these 54 to transplant. And of the total numbers that we've seen, there have been about 8 that have been transplanted, so 3.5%. Patients who were in the clinic did have lower rates of ER visits and inpatient admissions, comparing the 6 months before they came into the 6 months after in that early data from the first year of our clinic. So there is very clearly, it's a definite benefit to this clinic. We connect patients more to AUD treatment. And our next task is kind of what Brian was talking about at USC, is how do we extend this into the post-transplant realm? So we already have post-transplant recommendations that we perform at Michigan in terms of keeping patients connected with their AUD treatment providers, ideally with our treatment providers within the transplant group. And fortunately, Dr. Winder is our transplant psychiatrist as well. I also practice transplant, so there is some natural movement across this transplant continuum. But we really need to, I do think this is where this more work needs to be done broadly, is in what do we do, how do we manage these patients post-transplant. We certainly want to be getting regular biomarkers, and we do that about really every month. Really every time they're getting labs, we will be getting biomarkers along with that, but at least every month through that first 2-year time frame. As the data that Scott and Brian showed, that first year, patients post-transplant for ALD, the survival is very good and relapse rates are generally very low. But when you start moving out beyond that year, when people get back into their lives and they get back into, not needing to be so in the medical system as much, they're seeing us once or twice a year, that can be a time that can be kind of high risk for some of those behaviors to come back. And so we automate our audit Cs, we automate many of our surveys that capture things like depression, anxiety, fatigue, pain, insomnia, other drug use, or other like tobacco or marijuana. And the big reason why we really want to do this, and why I would encourage everyone to do this and not just automate audit Cs, is because those other things that I mentioned, insomnia, depression, anxiety, all of that pain, those are relapse triggers. So those are things that can trigger a relapse if we don't find them and we don't deal with them. And many of those things like insomnia, pain, et cetera, are very much in a medical professional's wheelhouse. So finally, I just want to mention, how do we think about integrated care and what kinds of things need to happen for integrated care to happen really well? And it's a combination of tasks that need to be performed, and then how we perform that task and the environment in which we perform that, and largely the communication and relationship factors that we have amongst our team members. Who's going to track down that positive path, and who's going to talk to the patient, and how do we work with them within a team to get that in? These are just some of the things that we're thinking about as we think ahead to how can we extend the work that we've done in the post-transplant period. So with that, I'll finish and we can start taking questions.
Thank you all. We do have some questions in the chat that I'd like to bring forward, and please continue to utilize that, and we'll try and move through. Some of these questions have been answered by some of our presenters as we're going through, but I'm going to start bringing up some of these. One that I think is a really important question for us to discuss is, do we run into issues getting insurance authorizations for listing in patients who do not have 3 to 6 month abstinence or who have not undergone relapse presentation?
We have some issues with a certain, I would say very, very few insurance companies that require a set number of negative tox screens before they will list. But largely for early liver transplant and ALCAP, I think that's more accepted. And so we have not, to my knowledge, had issues with having insurance not want to approve that if we're saying this is something that we want to do on this particular patient. We sometimes have issues with insurance saying, okay, they have to go to this center versus that center. That can always be an issue depending upon what center you're at. But by and large, we have not run into large issues with getting coverage or having early liver transplant for ALCAP be covered. Though in our other patients who are waiting for transplant, sometimes we have to get, a set number of, 3 months worth of negative tox screens, that type of thing.
Okay. Another question, how is the use of positive marijuana with no medical card handled if marijuana is still illegal in your state? And I think obviously this is very state and center dependent, but if we have a patient that tests positive and does not have a medical card, any input on how we handle that?
So there's a great survey that was done, and I can't cite it off the top of my head, in the heart transplant world. It's several years old. I can find it and put it in the chat, where it was a large response rate from heart transplant clinicians across the United States. Legality was a huge factor in whether or not these clinicians felt that a patient's cannabis use was appropriate or not. And we contend in the paper that I cited that legality is insufficient. It's not a metric that we should really even use in the vast majority of cases. Patients who've been incarcerated for drug-related charges, I think that could be clinically relevant, as a marker of the severity of their substance-related problem, not as a marker of worthiness or moral, caliber of the person. But I think unequivocally, legality is insufficient. The two legal substances, alcohol and tobacco, kill vastly more people, and they are legal. So we get hung up on, well, is it legal or not? It's a mess. It's federally illegal in the United States, and then it's this smattering of legality throughout the states. So I really think it's the prerogative of us to evaluate the context of use, stay consistent with our decision-making, create reasonable team standards that we adhere to, and be willing to investigate our own decision-making and outcomes. And of course, we need to study it more, but more and more studies are coming out. But I would really encourage all of us to just dispense with this legal, illegal stuff. The opioid crisis was largely contributed legally by physicians. So I think that's a peripheral issue.
I think a question that kind of piggybacks off that is, how are the non-discrimination laws specific to medical marijuana use and transplant denial impacting patient selection? So is that kind of taken into, account as well?
I'm not an attorney, and I don't have expertise about the legality of transplantation with regard to substance use. So that caveat, I believe this actually happened. My home state of Utah actually, I think, was implicated in a lawsuit of this regard. I think if an attorney could prove that a transplant team had unfairly and prejudicially excluded a patient simply based on the fact that they used cannabis, I think that the team could be liable. However, if there's a medical concern about it in terms of like cannabis hyperemesis syndrome or addiction, drug interactions, patient's cognition, the presence of psychosis, all of these are well-documented risks of cannabis. I don't think that a transplant team would be held liable, but that's my kind of amateur medical opinion about such a legal matter.
Another good question in here: will the age of a patient impact the listing decision? And this doesn't specify whether we're talking about alcohol use disorder or marijuana use, but a 22-year-old versus a 65-year-old, is that going to impact our listing decision?
I don't think so. I'd be curious what you think, Brian. I don't think it's something where we would be our heartstrings are kind of tugged a little bit more by younger patients. I think more so. There's no protocol in this as that we need to, list younger people over older folks. I think we just tend to kind of go, oh, they're so young, and feel badly for them. But
yeah, you're exactly right. I think subjectively we've all been there where we might be more willing to take a higher risk younger patient because they pull on your heartstrings. But objectively, at least from an alcohol standpoint, younger age has always been a consistent risk factor for alcohol relapse. So I think, as transplant providers, you need to be aware that, a younger patient might be a different phenotype from someone who's older with alcohol use disorder and may need more aggressive management of their alcohol use disorder.
And anecdotally, we've seen, and I think Scott would agree with this, that often, and Brian as well, often our younger patients with AUD and ALD, especially with severe ALC-HEP, they just come with so much more psychosocial complexity. They've really often never had a period of time in their life from their teens onward where their brain was not, being kind of affected by a substance of some kind. And again, it's usually multiple substances. It's not just one. And so oftentimes their executive function, their ability to just function, like make phone calls, set up appointments, do kind of some of the basic tasks of adulthood has been really hampered by such long-term and heavy substance use from a very young age. So yeah, they often, while they tug on our heartstrings, I think objectively, as Brian alluded to, when you look at the outcomes data, some of which Brian recently published, they actually do worse. Younger women, younger female patients under age 40 who are transplanted for ALD have higher risk of mortality at 5 years by a lot, like 1 in 4, 25%, 25% dying at 5 years post ALD transplant. And that's because of recurrent alcohol use. So objectively, some of these younger patients may actually do worse post-transplant for a variety of reasons.
How are patients with a MELD greater than 25 evaluated differently than those with a MELD less than 25 during evaluation?
So we now don't have, at USC by protocol, we don't have a MELD cutoff and we don't have an absence cutoff. So we treat everyone's evaluation the same way. That being said, I do think that the period pre-transplant, if you're able to consolidate, therapy for alcohol use disorder, that's always best to do pre rather than post. So if a patient can wait, that's always best.
Yeah, I would agree. I think we do the same thing. We don't have a specific MELD that we're doing something different, on which we're doing something radically different. We will maybe be more willing to, forego extensive AUD treatment, or, say, okay, they didn't do a whole lot of it because their MELD is 33. That's fine. We'll, go ahead and transplant them. They have enough. But I agree with Brian that more AUD treatment consolidation in the pre-transplant period is always better.
And this one was answered in the chat, but it seems like a good one to talk about as well, is pertaining to the SALT algorithm. It seems that it would be difficult at times to apply the 10+ drink information objectively, especially in encephalopathic patients. And how would we suggest working around such? And Dr. Winder, you answered that in here, but I wondered if we could just talk about this some more.
So Dr. Winder kind of put some important information. What I'll add to that is that encephalopathic patients are very challenging, and that's a time when you have to rely on the on the surrogates really for the history, but you often can't evaluate things like insight or motivation, or even whether the patient even wants transplant. And we found in Accelerate that actually encephalopathy was a risk factor for alcohol relapse. And I think that it's really just because we're not able to get this full evaluation. Not that they're inherently higher risk is at least my theory. But that being said, almost half of the patients had encephalopathy. So I don't think it's really realistic to say that we can't transplant these patients because there's such high need. So I think that we need to do a better job in terms of how to evaluate these patients accurately. And you really have to hunt down these surrogates and try to get as good of an evaluation as you can. And it often becomes, how strong is their social support? But I do think, just practically speaking, is that it's kind of this pull at your heartstrings, right? You have to remain objective, is that if you can't get enough information to make you feel comfortable proceeding with transplant, you have to say no. I think it's a hard decision, but I think that's what I try to remind people, is you have to be able to say no.
And that's really challenging. I think Brian touches on something important in this question of encephalopathy. I think 2 points. Number one, if people are so encephalopathic that we can't have any kind of a meaningful conversation with them, or intubated or sedated or what have you, we will not proceed with early liver transplant for those patients if we have no ability to talk to them, because so much of the assessment, as Scott and Brian have said, rides on what is the patient's own insight, what is their own understanding, what is their own commitment to AUD treatment and knowledge and understanding, all of which can be changed over time and developed over time. But I think you do have to have an assessment of that. So in our practice here, if we can't talk to our patient, if we don't have the ability to have a meaningful conversation, even if we have great surrogates, we don't go forward with it, because it needs to be the patient driving, some of this desire for transplant, to know that they actually want it. I think it's also interesting with encephalopathy and just kind of a research area I'm curious about as well. We put encephalopathic patients through alcohol treatment, which is extremely cognitively demanding. And I wonder, like, how much do they actually get out of it if they're really encephalopathic? Are they really able or capable of learning and doing what they need to do in that pre-transplant period where they're so encephalopathic? And so do we need to really be rethinking that, like, okay, once they're transplanted, yes, they've had some alcohol treatment, but we need to go back to square one and like do and just do that all over again, and make sure that we've really consolidated it now that they have, no less encephalopathy, hopefully, or none, and are able to kind of cognitively do that work that is really, a really intense cognitive process, especially when you're dealing with, kind of overwhelming medical issues as well.
I mean, let's make a kind of an analogy. I mean, imagine if the surgeons couldn't get a CT or an MRI around the time they needed to make clinical decisions. I mean, we can't scan the mind and discover intentions, expectations, and insight and motivation. The clinical interview to the psychologist is the CT scan to the surgeon. It allows for planning. It allows for risk stratification. I guarantee if you got to a point where like a hospital couldn't feasibly image a patient and we had to make these massive decisions, everybody would turn and say, well, what do we need to do upstream? I mean, what a crisis. I mean, it gets to a point where we can't even take a picture of them. We can't even. And so I think this is an argument for, yes, we've published on insight, which is a key variable that we keep talking about. Dr. Mellinger and I just published a systematic review in liver transplantation about this. And some of the feedback that came back from the reviewers was really poignant. They're like, you think you can really do these interviews in encephalopathic patients? Yes, you guys can talk about this insight stuff. It's a rich literature in the addiction, and I still think there's something there, but I really took that reviewer's criticism strongly. I mean, if we can't access the psychological data around the time of transplant, which we need, it is an argument to make these initiatives more common in our health systems, like Dr. Lee and Dr. Mellinger just talked about: upstream, multidisciplinary, well-funded, well-organized, well-staffed initiatives to accumulate data about people long before we have to make these decisions. So I think that we may not be able to resolve this encephalopathy question, but we can turn it on its head and use it to argue for more resources so that we don't find ourselves in this quandary as often.
I think it also lends itself to kind of a discussion of what I think where we are in this field right now is kind of where we were at with transplanting liver cancer before we had Milan criteria to define what were good post-transplant outcomes or not good outcomes. And so defining, I think, what is a good relapse risk, like, or what is a good post-transplant relapse rate for a population going through early liver transplant is also critical to make sure that we know, like, okay, that we're judging people as high risk of relapse. Well, they're all high risk, so we know that they all need to do something before and after transplant. But as a population and as a field, when do we know that we've done a good job with this population? Like, what's the post-transplant relapse risk that we are saying, yeah, all right, that's the ticket, that's really the number. Because when you compare the post-transplant relapses that have happened from the Accelerate study that Brian talked about, from the Quick Trans prospective study that was just published earlier this year out of France, they found about a 33%, 25 to 35% relapse risk at 2 years after transplant. And this was in a really well documented, timeline follow back, really looked at the data really well. Is that good? Is that bad? What do we think of it? Like, we don't want people to relapse, but like, is that a good, a good number? Or it's better than the 70% post inpatient alcohol treatment relapse risk at 1 year. So it's that we're doing better than the AUD treatment world with this in a highly selected group of patients. But I think that's also something that we need to think about as a field. What do we consider success here as a population in terms of population metrics?
I could just add one more thing on this topic. Jess mentioned the Quick Trans study, which is, the largest prospective study in this field that was published this year in the Lancet GI by the French group. But they had a protocol that selected patients for early transplant based off of a scoring tool. And they actually had a different scoring system for encephalopathic patients versus not.
Oh,
So
interesting.
we at USC, there are a couple recent very controversial encephalopathic patients, and the only way to settle it was try to use this as something objective. And at least it made, the selection committee feel better about their decision. But that's something that you could consider from a practical standpoint.
Yeah, that's a good idea.
A few questions came in, kind of going around along the same about risk mitigation strategies for cannabis use, both before transplant and then after, and how to prevent cannabis use post-transplant. And then I think that goes along with, are we trying to prevent it post-transplant as well? And what resources do we have for patients?
Yeah, I sound like a broken record and I apologize, but if we don't know if the patient's addicted or not, that's a key fork in the road. If we don't know if this is medically managed cannabis, and it could be edible cannabis, it could be smoked cannabis, then that's also an important fork in the road. So it's difficult to just kind of pronounce kind of this Caesar thumbs up, thumbs down on cannabis without kind of this nuance. Again, and I don't mean to monopolize here, but that paper that I referenced, we actually made some as best of high resolution practical recommendations as we could about this. And if we think that a patient's cannabis use is going to exacerbate their psychiatric condition, if it's going to interact with their medications, if it's going to pose some sort of risk to their transplant course that we're worried about. For example, a patient who has a history of auditory hallucinations, in my estimation, should not be smoking cannabis because of the link between psychosis and cannabis. And a patient who has been in the ER with chronic nausea and vomiting, and there's data out of Colorado, a place where cannabis is used once in a while, documenting that their hospitals were extremely overrun in some studies that show that the level of chronic and refractory nausea and vomiting, which was largely attributed in part to cannabis hyperemesis syndrome and cyclic vomiting, if we see that in a patient's chart, for nutrition reasons, the hepatologists and the surgeons are going to care about that. So these are the types of, or if somebody has chronic anxiety and panic attacks and they're using high potency THC cartridges of 80 and 90%, one of the main side effects of high potency THC is anxiety. These are really stable recommendations, practical and prudent recommendations that we can make to people to mitigate risk. But a lot of people will return to use after transplants, kind of like you can't take the graft back. And so then you pivot. And a lot of times it's kind of like harm reduction. Okay, you're going to use it. Could you use edible? Because the reliability of how THC is delivered into your bloodstream after you're burning something and goes to your brain is really unreliable. So the pharmacists often will say, can you at least use an edible formulation? Can you use it at the same time during the day? Because we don't want to lose track of them. And I know that pharmacy at our place has struggled with the tacro levels up and down in patients who are erratically using cannabis. So the way this looks before transplant and after transplant kind of depends on all this stuff. Addicted or not, team policies, risk stratification, a multidisciplinary discussion about what would happen if the patient returned to use, how worried about it are we. It's a mess, but it takes some practice, and I think it is possible to make some recommendations that are reasonable and defensible and ethical.
Definitely. Well, I think we've gotten through the majority of these questions, and the ones that were sent in that all seem to, have the common themes. I want to thank all of our speakers, and I'm going to turn it back over to Christina now to close us out.
Thank you, Megan, and thank you, everyone. On behalf of the Alliance team, I want to thank you all so much. And Megan, thank you for your help today in facilitating today's discussion. It's clear that there are a lot of questions and thoughts and lots of discussion around this topic, and it's something that's important to the community. I want to thank you all for your time today And as usual, along with all of our other conversation series, we will be sharing the presentation today, the recording, as well as the slides as a handout. And with that, I just want to wish you all a great day. And thank you again for joining us for this conversation today. Have a good day, everyone. Bye-bye.